The anal canal is 3 centimeters long and extends to the dentate line. The rectum is approximately 15 centimeters long, and the distal half to 2/3 is extraperitoneal. It has several prominent folds, called valves of Houston. The rectosigmoid junction may have an acute angle in some cases. The sigmoid colon can be stretched up to 80 centimeters, but can crumple down to 30 centimeters when the scope is straightened. Conforming to the pelvis, it passes anteriorly before moving posteriorly to the left paravertebral gutter, often producing a clockwise spiral loop. The sigmoid descending colon junction may become very acute if there is a large sigmoid loop or retroperitoneal fixation of descending colon low in the pelvis. The descending colon is retroperitoneally bound and an air fluid level is often seen. The splenic flexure, below the left costal margin, is variably fixed by the phrenicocholic ligament. The transverse colon has a typical triangular configuration and is enveloped by the transverse mesocolon peritoneum. The degree of droop of the transverse colon towards the pelvis accounts for the variable bowel length and influences the acuteness of the hepatic flexure bend. In older patients, there is often a mid-transverse angle. The hepatic flexure is at the right costal margin. It is usually negotiated semi-blind around the acute angle. Most of the ascending colon is retroperitoneally fixed and runs anteriorly from the hepatic flexure to the cecum. The pole of the cecum, often contaminated with bowel content, when cleaned may reveal the triradiate fold, which is the fusion point of the 3 teni coli. The appendix orifice is noted. The ileocecal valve is located at the medial or posterior medial wall. An arrow drawn on the bow of the appendiceal orifice will usually point to the ICV orifice. The terminal ileum is reached by intubation of the ileocecal valve between the superior and inferior valve lips. The terminal ileal surface appears granular in air, but the villi will float up underwater. Blind areas may exist in the cecal pole between the ileocecal valve and appendix. This area should always be directly visualized. Likewise, at the hepatic flexure, a blind spot may exist, and this may be best evaluated by careful retroflexion of the scope in the cecum. Withdrawal technique from the cecum is important for optimizing lesion detection and efficacy of colonoscopy in cancer diagnosis and prevention. Withdrawal times in excess of 6 minutes are associated with improved adenoma detection rates. Time is a surrogate marker for the thoroughness of inspection. Suctioning all pools of fluid and residue with irrigation helps to seek lesions beneath such collections. It is important not to fly past the mucosa of sharply angulated or excessively telescoped portions of colon. Slow staccato in and out movement by withdrawing 3 to 5 centimeters and reinserting 2 to 3 centimeters is useful in the transverse colon and other poorly visualized areas. We advocate a 2-pass examination of all the flexures and the sigmoid colon. Retroflexion of the scope in the rectum is undertaken to thoroughly inspect the anal-rectal junction.